Good morning, everybody. Welcome to Neurocritical Care Update 2022, conducted by ISCCM Hyderabad branch. My name is Dr. Siddhartha Reddy. I'm Consultant in Critical Care Medicine, in charge of Medical ICU, Apollo Hospital, Jubilee Hills. I'm faculty of Intensive Care Medicine, DNP course also, and a member of Indian Society of Critical Care Medicine. So my topic is about acute ischemic stroke. Acute ischemic stroke will deal with case-based and evidence-based approach. So start with case one. We have 62-year-old male patient arrived in emergency department with history of deviation of mouth speech since 6 a.m. today morning, and he reached here at 6:45 a.m. Patient past medical history is he is type 2 diabetic on oral hypertensive medications, hypertensive on Telma 40. He is a ex-smoker. So with this history, what is your initial assessment, how you evaluate this patient, and with history and the clinical examination, what is your provisional diagnosis, what investigations do you order, and what is the drug of choice for the thrombolysis of ischemic stroke. So this is the non-contrast CT brain done for this patient, and here you can see clearly there is no any hemorrhagic conditions like ICH or SH. It looks like a normal CT scan brain, no effacement of cardiomedical differentiations. So what is the initial management? Initial management is ABC. Always remember ABC, airway, breathing and circulations, protect the airway. And if patient is not protecting the airway, intubate the patient and ventilate the patient, maintain the hemodynamics and regular neurological assessment, brain imaging, evaluation of appropriate thrombolytic therapy. So timeline for action is the time of from the time of arrival to the emergency to the evaluation. By patient must take less than 10 minutes. For stroke and neurological expertise contact, you must take 15 minutes. Within 20 minutes, you must get the NCCT brain or MRI brain. 40 minutes or sooner, interpretation of neuroimaging by the radiologist or neurophysicians. And if the patient fits the criteria of IV thrombolysis therapy, then you have to administer the IV thrombolysis by altiplase less than 60 minutes. It is the gold standard what followed internationally. In Western countries, we have pre-hospital thrombolysis facilities. Even ambulances are equipped with CT scan to do quick CT scan rate before reaching the hospital, and they will administer the IV thrombolysis before patient is the emergency. So, what are the causes of ischemic stroke? The results for ischemic stroke is the result from the appropriate interpretation of the focal cerebral blood flow. Most common causes are the embolic and thrombotic occlusions. The most 70 to 80% of the patient you will see these embolus or thrombotic occlusions. Other causes are abrupt occlusion of small penetrating arteries and arterioles, single or multiple high-grade arterial stenosis with poor blood flow through collateral vessels, arteritis, arterial dissections, venous occlusion, profound anemia, and profound hypoviscosity. Coming to airway and ventilatory support, why we need airway protection? Because the patient is having brainstem infarct, they cannot breathe, they will have aspirations. So to prevent aspiration pneumonia, to prevent atelectasis, you have to secure the airway. And to clear, if patient is unable to clear the secretions due to bulbar weaknesses or altered level consciousness, you have to secure the airway and prevent hypoxemia, because hypoxemia will worsen the cerebral ischemia. The goal is to keep the SaO2 greater than 95%. During endotracheal intubation, we have to use the short-acting sedatives like propofol and muscle relaxant, and do the quick rapid sequence inductions and maintain the hemodynamic status. Try to prevent hypotension during intubation. And coming to mode of ventilation, so no trial has suggested the correct mode of ventilation. So normally we'll use the volume control ventilation as initial mode, but our goal is to maintain the eucapnia of PaCO2 of 35 to 40 millimeter of mercury. Coming to BP and fluid management, the initial phase of the ischemic stroke, the patient will have a high blood pressure This is normal response to pre-stroke levels within 7 days. Reasons is the physiological compensation by cerebral ischemias and increased raised intracranial pressure also will lead to high blood pressure, pain, long-standing underlying hypertension, and full bladder physiological response to hypoxia. Theoretical advantages of treatment of hypertension is we have to look into the hemorrhagic transformation if ischemic infarct, transformation infarct, and cerebral edema. Lowering blood pressure comprises of the cerebral blood flow, area surrounding infarct, and stroke extension. As elevated blood flow should not be lowered unless the patient receives the thrombolytic treatment. Hypertensive emergencies like aortic dissections, hypertensive encephalopathy, acute renal failure, acute pulmonary edema, or acute MI. This is auto-regulation. Already in previous sessions, the speakers has covered up all this. I will skip this one. In case of cerebral ischemia, auto-regulation is lost. So always remember keep the mean arterial pressure of higher level. So coming to ischemic penumbra. So why we have to keep the mean arterial pressure of higher level, because at the initial phase of acute cerebral infarct, the core area, the central part of the ischemic will be more affected when compared to periphery areas where there will be some insult, but still the tissues are viable. Regions of blood flow will gradient depressed blood flow. Tissue with the lowest cerebral blood flow irreversible damage in the infarct. The region surrounding the infarct will call as a penumbra, ischemic and dysfunctional, but potentially salvageable. BP reduction in acute ischemic strokes worsens the penumbra and hastens extension of infarct. Assess patient volume status and correct dehydration. So by giving IV normal saline infusion, preferably avoid hypotonic fluids. If feasible, do MRI with the DWI, diffuse weighted image, and perfusion weighted image. Diffuse weighted image represents the core of the infarct, and perfusion weighted image indicates the region of hypoperfusion. Subtraction of the perfusion weighted image and diffuse weighted image will give the area of ischemic penumbra. In this slide, where we can see that the initial stages, the core area will be most affected, penumbra will be a larger size. If reperfusion is restored, then the penumbra area will be salvaged, so that the ischemic area and infarct area will be very less when compared to non-reperfusion patients. So coming to BP management to eligible thrombolysis, try to maintain the blood pressure. If blood pressure is more than 180 degrees systole and diastole of 180 millimeter of mercury and diastole of 110 millimeter of mercury, use labetalol 10 to 20 mg IV bolus and monitor blood pressure every 1 to 2 minutes and repeat the bolus till you get the desired blood pressure results. After, during and after treatment of thrombolysis, monitor the blood pressure, check blood pressure every 15 minutes for 2 hours and every 30 minutes for 6 hours and every hour for remaining 16 hours. So diastolic, if diastolic is more than 140 millimeter of mercury, use sodium nitroprusside 0.5 mg per kg per minute IV infusion as initial dose and titrate to desired blood pressure. Systolic blood pressure is greater than 230 or diastolic is 121 to 140. Use labetalol 10 mg IV for 1 to 2 minutes. May repeat or double labetalol every 10 minutes to maximum doses of 300 mg or give initial labetalol dose and then start labetalol drip at 2 to 8 mg per minute, or use nicardipine 5 mg per hour IV infusion as initial dose and titrate to desired effect by increasing 2.5 mg per hour every 5 minutes to maximum of 15 mg for blood pressure not controlled by labetalol. Consider sodium nitroprusside. Systolic blood pressure is high, so 180 to 230, or diastolic is 105 to 120 millimeter. Use labetalol 10 mg IV for 1 to 2 minutes. May repeat or double labetalol every 10 to 20 minutes to maximum doses of 300 mg, or give initial labetalol doses and then start a labetalol drip at 2 to 8 mg per minute. Do neurological examination. Neurological symptoms are the most critical. For the purpose of treatment, onset of assumed as the time that the patient is last known to be symptom-free. National Institute of Health and Stroke Scale, it's the most important prognostic information. In NINDS trial of RT-PCR, score of greater than 20 has a high risk of ICH of 17%. Score of less than 10, risk of ICH is only 3%. Common pattern of neurological impairments in acute stroke is left dominant hemisphere or major branch cortical infarctions. Most symptoms we have seen is aphasia, right hemiparesis, right-sided sensory loss, right-sided spatial neglect, right homonymous hemianopia, impaired right conjugate gaze, right non-dominant hemisphere major or branch cortical infarct, left hemiparesis, left-sided sensory loss, left-sided spatial neglect, left hemianopia, homonymous hemianopia, impaired left conjugate gaze, deep subcortical hemisphere of brainstem, hemiparesis, pure or motor or sensory loss, pure sensory stroke, dysarthria, including dysarthria, clumsy hand, ataxia, hemiparesis, no abnormal to cognition, language, or vision. If brainstem is involved, motor sensory loss is an limbs. Cross signs are on same side of the face and other side of the body. Disconjugate gaze, nystagmus, ataxia, dysarthria, dysphasia, cerebellum, ipsilateral limb ataxia, gait ataxia. This is the NIHSS score. So we have 11 parameters to be evolved. Those parameters are the loss of consciousness, best gaze, visual, facial palsy, motor arm, left arm and right arm, motor leg, left leg and right leg, limb ataxia, sensory, best language, dysarthria, extinction or inattention. The score is 0 to 42. Diagnostic workup. All patients must get CT scan brain, and brain MRI may be considered at qualified centers. Electrocardiogram, blood glucose, serum electrolytes, renal function test, complete blood count, including platelet count, prothrommeter, international normalized ratio, activated partial thromboplastin time. Selected patients, hepatic function test, toxicology screen, blood alcohol determination, blood alcohol pregnancy test, oxygen, saturation, RTA blood gas test, chest radiography. If lung disease is suspected, lumbar puncture. If subarachnoid hemorrhage is suspected, CT is negative for blood. Electrocardiogram if seizures are suspected. Sorry, electroencephalography if seizures are suspected. Non-contrast CT brain actually identifies the ICH, helps discriminate non-vascular causes like brain tumor, early signs of infarctions in the 3 hours time window, sulcal effacement, hypodensity of brain parenchyma, or loss of gray and white matter differentiation, slightly increased risk of hemorrhagic transformation of IV TPA, but not as a contraindication for TPA. Widespread sensitivity of early infarction, involvement of greater than 1/3 tether of MCA, high risk of hemorrhagic transformation following TPA. For patients who are candidate for RTPA, complete CT brain less than 25 minutes of arrival, interpreted within additional 20 minutes, and total interpretation time is 45 minutes, as we discussed earlier. Other CT modalities are CT angiogram. While ordering CT angiogram, patient has a normal renal function. There is no need to wait for renal normal creatinine levels. You can directly go for CT angiography to assess both intracranial and cervical circulations for stenosis and occlusions, usually in who present just outside of the treatment window for IV TPR, who may be candidate for intra-arterial clot lysis because it provides information to location and extent of clot, who cannot undergo MRI because of the pacemakers or other metal objects in the body, claustrophobic or critical illnesses. Perfusion CT assess cerebral perfusion of brain, capable of differentiating between regions of brain infarction and ischemic penumbra. MRI brain, better resolution of brain parenchyma, evaluates brainstem and cerebellum with high resolution than CT. DWA shows an abnormal signal within minutes of ischemic onset. PWA measures relative blood flow in the brain. Use of PWA and DWA identify patients who would benefit from revascularization therapy outside established 3-hour time window period for IV TPA. MRE evaluate blood vessels of the brain and neck. Coming to treatment, IV thrombolytic therapy within 3-hour window period. TPA, fibrin specific thrombolytic, activate plasminogen to form a plasmin that cleaves fibrin. NINDS RT-PCR stroke study, number involved in the study is 624, randomized to placebo or RT-PCR, 0.9 mg per kg IV, maximum 90 mg. Within 3 hours of the symptoms are there, half treated within 90 minutes. Trial has had 2 parts. First part, measured early response to TPA. No significant difference between TPA and placebo and neurological improvement 24 hours. Benefit for TPA group at 3 months for all 4 outcome measures. Part 2, measure 3-month outcome assessment using several rating scales, NHS, Barthel Index, Modified Ranking Score, Scale, Glasgow Outcome Scale. Long-term clinical benefit of TPA predicted by results of the Part 1 was confirmed. TPA group 30% more likely to have a minimal or no disability at 3 months. Symptomatic ICH within 36 hours is 66.4% in TPA group, only 0.6% in placebo. Mortality at 3 months is 17% in TPA group and 21% in placebo group. IV thrombolysis within 3 hours in the period is 4 studies, similar results. Star study, number included is 389. 43% of patients treated with IV TPA had independent functional outcome at 1 month post-treatment. Percent of symptomatic ICH is 3.3%. Mortality was 13% at 1 month. CAS study number included is 1,132. 36% of TPA treated patients had favorable outcome at 3 months. Symptomatic ICH is 4.6%. Mortality was 21% at 3 months. Eligible criteria, this slide looks a little bit clumsy, but inclusion is the clinical diagnosis of ischemic stroke with the onset of symptoms within 3 hours of the initiation of treatment. With the exact time of stroke is not known. It is defined as a last known patient will not be taken with a measurable neurological deficit. Exclusion criteria, historical, previous history of stroke, head trauma within and the period 3 months, any prior history of intracranial hemorrhage, major surgery within 14 days, gastrointestinal or genitourinary bleeding with the previous 21 days, myocardial infarction in prior 3 months, arterial puncture, attend non-compressive site within 3 days, within 7 days, a lumbar puncture within 7 days. Clinical, rapidly improving stroke symptoms, only minor or isolated neurological signs, seizures at onset of seizures with post-ictal residual neurological impairment, symptoms suggestive of a subarachnoid hemorrhage, even if the CT is normal. Clinical presentation consists of acute MI or post-MI pericarditis, persistent systolic blood pressure greater than 180 millimeter of mercury, diastolic BP greater than 110 millimeter of mercury, require aggressive therapy to control BP, pregnancy and lactation, active bleeding or acute trauma fractures. Laboratory, platelet less than 1 lakh, serum glucose less than 50 and greater than 400, INR 1 greater than 1.7 if on warfarin, elevate patient thromboplastic time if on heparin. Head CT scan, evidence of hemorrhage, evidence major early infarct signs such as a diffuse swelling of the affected hemisphere, parenchymal hypodensities or effacement of greater than 33% of the middle separated territory. So, regimen for treatment with IV RT-PCR is infuse 0.9 mg per kg, maximum of 90 mg over 60 minutes, with 10% of dose given as a bolus dose over 1 minute. Admit the patient to a intensive care unit or a stroke unit for monitoring. Perform neurological assessment every 15 minutes during the infusion of TPA, every 30 minutes next 6 hours, and every 24 hours. If patient develops severe headache or acute hypertension, nausea, vomiting, discontinue the infusion if patient is still being administered, or obtain the CT scan brain on an emergent basis. Measure blood pressure every 15 minutes for 2 hours, 30 minutes for next 6 hours, and every hourly for next remaining 24 hours. IV thrombolytic therapy beyond 3-hour window period. European Operative Acute Stroke Study, ECOS. 2 trials evaluate use of IV TPA within 6 hours of symptoms onset with moderate to severe hemiplegic stroke. ECOS 1 used the 85% of dose of MI, 0.1 mg per kg, maximum dose is 100 mg. More ICS than placebo, 20% versus 7%. RTPA was not more effective than placebo in improving neurological outcome at 3 months after stroke. ECOS 2 used 75% of dose of MI, 0.9 mg per kg, maximum dose is 90 mg. No significant benefit noted from treatment. Post ad hoc analysis, combination of death and defense was less with RTPA. American trial tested RTPA up to 5 hours following stroke. Results were similar in 1/3 of patients in both treatment groups. Rate of ICH was higher in treatment group, 7% versus 1.1%. Other thrombolytics like IV streptokinase, 1.5 million units of streptokinase, 100% doses used in a myocardial infarction doses. MAST1 and MAST-E used a 6-hour window period, asked 4 hours window period. All 3 trials were stopped early because of the high number of deaths and symptomatic ICH in treatment group. And COT, which is viperin-derived enzymes, cleaves fibrosis and promotes endogenous release of plasminogen activator from vessel wall. Desmotilase, protease found in the vampire bat saliva, similar to human plasminogen activator, works faster and causes a more sustained vessel recondylation compared with the TPA in lab models. Glycoprotein 2B3A antagonist, evaluated alone or EBAST in combination with low dose TPA, clear stroke trial. Post trial studying use of the ISCCM alone or in conjugation with escalate dose of place. Preliminary results promise for combination therapy, but not for a ISCCM alone. Marker for increased ICS of IV RTPA therapy based on the clinical variable, previous history of diabetes or cardiac disease, increased stroke severity, NH score greater than 20, advanced age, use of antiplatelet agents other than aspirin before stroke onset, elevated pre-treatment in mean arterial pressure. CT scan laboratory findings, early ischemic CT changes, in particular if exceeding 1/3 of MCA territory, increasing stroke severity, diabetes mellitus, elevated serum glucose, and low platelet counts. Intra-arterial thrombolysis, direct administration of intra-arterial thrombolytic agents into clot, passing through a catheter through clot and mechanically disrupting it, allows for a lower TPA dose and decreased risk of systemic hemorrhagic complications. Indications, MCA occlusion within 3 to 6 hours from onset, symptom onset, and have no or minimal signs of infarction on baseline CT. Disadvantages, time and expertise required for catheterization. PROACT trial, intra-arterial pro-urecanase plus IV heparin compared with placebo plus IV heparin in MCA occlusion less than 6 hours. PROACT 1, number included is 46. Superior recanalization rate compared to the placebo. ICH is 15.4% in pro-urecanase group versus 7.1% placebo. PROACT 2, statistically significant benefit with pro-urecanase treated patients having good 3-month functional outcome compared with control. Symptomatic ICH, 10% of pro-urecanase group and 2% of control. Combined IV and intra-arterial thrombolysis. Several pilot studies more effective than either therapy alone in acute and large vessel occlusions. IMS1, ischemic stroke and subarachnoid substantial neurological deficit, INS greater than 10. Number included is 18. 0.6 mg per kg IV TPA over 30 minutes within 3 hours from stroke symptom onset, followed by intra-arterial TPA within 5 hours if a vessel occlusion was still present on angiography. 3 months mortality rate and symptomatic ICH rate were similar in NINDS TPA stroke trial. No significant trend towards better clinical outcomes. Coming to mechanical thrombolysis, mechanical embolus removal in cerebral ischemic mercy retrieval devices in patients who are eligible for or fail ineligible or fail IV TPA therapy are included. Partial and complete recanalization in 46%. 46% is good neurological outcome at 90 days. Complications were reported in 7%. So coming to guidelines, 2019 guidelines, recommendations for mechanical thrombectomy. Patients eligible for IV altiplase should receive IV altiplase even if mechanical thrombectomy is being considered. Class of recommendations 1A, level of readiness A. In patient under consideration for mechanical thrombectomy, observation for IV altiplase to assess for clinical response should not be performed. Patients should receive mechanical thrombectomy with a stent retriever if they meet all of the following criteria. So pre-stroke MRS score of 1 to 2, causative occlusion of internal carotid artery or MCA segment 1, age is greater than 18 years, NIHS score of greater than 6, aspects of score of greater than 6. Treatment can be initiated through groin puncture within 6 hours of symptom onset. Recommendation is class 1A. Although the benefits are uncertain, use of mechanical thrombectomy with stent retriever may be reasonable for carefully selected patients with acute ischemic stroke who treatment can be initiated through groin within 6 hours symptom onset and who have a causative occlusion of MCA, M2 and MCA3 portion with MCA. Recommendation is 2B. Although benefits are uncertain, use of mechanical thrombectomy, stent retriever may be reasonably acute stroke who can be initiated within 6 hours and onset, who have a pre-stroke MRS score greater than 1, aspect less than 6, NIHS less than 6, causative occlusion is internal carotid artery proximal main, class of is 2B. Although the benefits are uncertain, use of mechanical thrombectomy with stent retrievers may be reserved for carefully selected patient with acute ischemic stroke in whom treatment can be initiated through groin puncture within 6 hours from onset, who have causative occlusion of anterior cerebral artery, vertebral basilar artery, posterior cerebral artery. Recommendation is class 2B. In selected patient of acute ischemic stroke within 6 to 16 hours of last known normal who have a large vessel occlusion in the anterior circulation met other Dawn and diffuse 3 eligible criteria, mechanical thrombectomy is recommended. Class is 1A. In selected patient with acute ischemic stroke within 16 to 24 hours of last known normal who have large vessel occlusion anterior circulation meet other Dawn eligibility criteria, mechanical thrombectomy is reasonable. 2E. Recommendation is 2A. So use of stent retrievals is indicated in performance preference to mechanical embolus removal in cerebral ischemic device. Recommendation is 1A. Technical goal of thrombectomy procedure should be perfusion to be modified thrombolysis in cerebral ischemia. 2B3 angiography results to maximize the probability of good functional clinical outcome. 1A. To ensure benefit and repercussion of modified thrombolysis in cerebral ischemic rate, 2B3 should be achieved as early as possible within therapeutic window. Recommendations 1A. In a 6 to 24 hours thrombectomy window evaluation, the treatment should proceed as rapidly as possible to ensure access to treatment for the greatest proportion of patients. Recommendations 1. via direct aspiration thrombectomy as first pass mechanical thrombectomy is recommended as non-inferior to stent retriever for patients who meet all the following criteria: pre-stroke MRS score of 0.21, causative occlusion of internal artery or M1, age greater than 18 years, NHS score greater than 6, aspect greater than 6, treatment initiation through groin within 6 hours symptoms. Recommendation is 1. It is reasonable to select an anesthetic technique during endovascular thrombectomy as for acute stroke on the basis of individualized assessment of patient risk factors, technical performance of the procedure and other clinical characteristics. 2A. Use of proximal brain guided catheter or a large bore distal access catheter rather than the cervical guided catheter alone in conjugation with stent towards may be beneficial. Recommendation is 2A. Treatment of tandem occlusion, both external and internal occlusions, when performing mechanical thrombectomy may be reasonable. 2B. Safety and efficacy of IV glycopride 2B3A inhibitors administered during endovascular stroke treatment are uncertain. Use of salvageable technical agent, including intraarterial thrombolysis, intraarterial fibrosis, may be reasonable to achieve mechanical modified thrombolysis in cerebral ischemic rate. 2B3 angiographic results. Thank you. Minutes అవుతుంది సార్ ఏం కదంటారా అయిపోయింది